Gina is a 24-year-old Latina who was married 2 years ago to a migrant worker. She and her husband moved to the U.S. a year ago. She works as a house cleaner when they are in one location long enough for her to join a cleaning team. All of her family members live in Central America. She has no health insurance and presents to your clinic, a federally qualified health center. In halting English, she tells you she thinks she is pregnant. Her last menstrual period was 3 months ago. She appears worried and is tearful when she speaks. How do you counsel Gina? What epidemiologic data might be relevant to Gina's care? Researchers have found that of the 6.6 million pregnancies in 2008, 51% were unintended. Unintended pregnancy rates varied by race and ethnicity, even when controlling for income. Black women had the highest rate of unintended pregnancy, followed by Latinas. Previous research has suggested that higher unintended pregnancy rates among these groups reflect the difficulties that many women in minority communities face in accessing high-quality contraceptive services and in using their chosen method of birth control consistently and effectively. Latina women have higher rates of unintended pregnancy and birth rates than white women. Between 2001 and 2008, Latinas had the highest rate of unintended birth, approximately 42%. During this period of time, the unintended birth rate remained the same among Latinas, but increased in other populations. The proportions of unintended pregnancies ending in abortion declined during the same time frame. Being aware of these data about the rates of unintended pregnancy, you wonder if Gina is upset because the pregnancy is unintended and possibly unwanted at this time. What social, economic, and cultural considerations will you, a non-Latino clinician who does not speak Spanish, need to be aware of as you work with Gina? According to census reports, 56% of Latinas who live in the United States are married, and 58% have children younger than 18 years. Their median age is 26.6 years. About half of Latinas at large self-reported that they speak English less than very well, defining them as individuals with limited English proficiency. Scholastically, 43% of Latinas have a 12th grade education or less, and only 11% have a bachelor's degree or higher, compared to 12% and 26% respectively for white women. Latinas are more likely to be employed in low-paying, part-time or seasonal jobs and experience twice the rate of unemployment compared to white women. Weekly income for a full-time employed Latina in 2018 was $674, compared to $683 for African American women, $907 for white women, and $1,083 for Asian women. Starting in January 2014, the Affordable Care Act expanded access to health insurance by offering new coverage options for low and moderate-income individuals. Before the passage of the ACA, the uninsured rate for Latinos was 26%, the highest among ethnic groups. The ACA reduced the uninsured rate among Latinos to 22% in 2016, although this remains much higher than the uninsured rate for whites, which was 9% in 2016. For these reasons, Latinas are vulnerable to poverty-related health conditions and may lack health insurance or financial means to pay for quality health care. Latino families often practice a strong religious faith in which premarital sex is forbidden for women. Children are hoped for and expected after marriage. Many Latinas are disadvantaged in sexual communication and negotiation. They have less control over their sexual relationships than men. Young Latinas may feel discomfort in discussing sex and reproductive health issues with parents or teachers. Birth control is considered taboo as premarital sex is forbidden for women. Sexual education is seldom addressed verbally within the Latino family structure. Conversations regarding sex topics are often left to the parent matching the child's gender. Mothers are seen to be the primary communicator when it comes to sexual topics. The church, largely the Catholic Church, and school systems are predominant. How might this information about Latino culture and demographics inform your approach to counseling Gina? What are the first steps you might take to assist her? As a first step, you ask Gina what her preferred language is. She tells you it is Spanish. Before continuing with the visit, you arrange for a promotora to assist you. The promotora, named Rosalina, is currently helping another clinician. When she arrives, you ask Rosalina to explain that a medical assistant will be coming in to draw blood for a pregnancy test and that you will speak with Gina again when the result is back in about a half hour. Promotoras de Salud is the Spanish term for community health workers. Because promotoras usually come from the communities they serve, they are uniquely able to be a cultural bridge between community-based organizations and their clients. They generally share the same language and understand the traditions and needs of their community. Their personal knowledge of their community can provide critical information for clinicians and other health professionals. Promotoras are viewed as counselors who provide emotional and social support. They act as health educators, health advocates, care navigators, translators, and service coordinators. Some promotoras work for a specific health clinic, others are hired by nonprofit organizations, community groups, or public health departments to work within the community across groups. Their outreach work occurs in clients' homes, community centers, health clinics, hospitals, schools, work sites, shelters, and migratory and seasonal agricultural worker labor camps. Various programs exist across federal agencies to train promotoras in health education. Amigas is a bilingual educational outreach intervention designed to help promotoras and other lay health educators increase cervical cancer screening among Latinas who have rarely or never had a Pap test. Amigas stands for Ayudando a las Mujeres con Información, Gaia y Amor para su Salud. In English, this means helping women with information, guidance, and love for their health. A randomized controlled trial funded by the Centers for Disease Control and Prevention showed that the Amigas program was effective in promoting Pap tests among Latinas ages 21 to 65. The study found that 52% of Latinas who participated in the full Amigas program received a Pap test within 6 months, compared with 25% of Latinas in the control group. 30 minutes later, a preliminary pregnancy test is positive. You enter the room with Rosalina. You speak directly to Gina while Rosalina translates for you. You tell Gina that the test is positive. Gina bursts into tears. You quickly reassure her that it is still early in the pregnancy, and if she does not want to continue with the pregnancy, they can discuss abortion. When Rosalina translates for you, Gina becomes upset, speaking in Spanish in a raised voice. Rosalina continues to speak with Gina. She then lets you know that your assumption is wrong and that Gina is offended that you would suggest an abortion, as she is Catholic. You apologize and ask Gina why she is crying if she wants the pregnancy. Mi familia, she says. Rosalina, seeing your confusion, explains a bit about Latina cultural norms around pregnancy and postpartum. Rosalina explains that traditional Latina support systems are tied strongly to the family, including extended family members. Pregnant Latinas often seek support from a maternal figure, which is difficult for women who come to the U.S. if their mother stays in the country of origin, as is the case for Gina. In addition, Latinos support families through a system of social bonding, mutual help, and support established around Catholic religious milestones like baptism. Godparents, or padrinos, have a lifelong supportive relationship with the child. Rosalina explains that Gina feels sad and worried that she won't have her mother nearby during pregnancy and her child won't have padrinos. Rosalina tells Gina that there are several Latina community groups where she would be welcomed and offers to accompany her to a gathering the following week. With Rosalina translating, Gina tells you she is also worried about caring for the baby alone when she must stay at home and avoid physical activity for the first 40 days after birth. You ask Gina why she will need to stay home and avoid activity. She replies, "Cuarentena," and asks Rosalina to explain. Rosalina tells you the quarentena is a 40-day period after delivery when the new mother must avoid certain foods, physical labor, and air drafts. You respectfully tell Gina that it will be healthy for her to be increasingly active after birth to avoid blood clots and other complications. Gina begins to cry again. You say, "I didn't mean to scare you by mentioning possible complications. Most women have no complications after birth." Rosalina explains to you that going back to work or even going out of the house is sometimes considered taboo and that many women feel guilty if they return to activities within 40 days of birth. Rosalina tells Gina that this is not considered so taboo in the US and that she returned to activities a week after her son was born, went back to work 6 weeks later, and had the blessing of her mother and grandmother. Gina stops crying and appears to be relieved. Rosalina then translates for you. Gina also says she is worried about finding health care for herself and her new baby. She says they have not needed any health services since they arrived in the US, but currently have no health insurance. About 35% of migrant and seasonal workers interviewed in 2013 and 2014 reported that they had health insurance. Among them, about 1/3 said their employer provided the insurance. 37% reported that they had insurance provided by the government, and about 1/3 said that they or their spouse or family member paid for insurance themselves, or they had insurance under their spouse's employer's plan. About 62% of migrant and seasonal workers used a healthcare provider in the U.S. sometime in the last 2 years. The last time they visited a healthcare provider, 35% of workers went to a private medical doctor's office or private clinic. 32% said they visited a community health center or migrant health clinic, and 10% went to a hospital. The same study found that 43% of migrant and seasonal workers paid for their last healthcare visit out of pocket. 12% said they had Medicaid or Medicare. 11% reported that the cost was covered by health insurance provided by their employer, and 9% said the majority of the cost was covered by health insurance that they or their family had purchased themselves. About 10% used a public health clinic that did not charge for services. The most common difficulty migrant and seasonal workers reported related to access to health care was cost, which was reported by 26% of respondents. In the U.S., there are 166 federally funded migrant health center entities, all but 15 which are jointly funded community and migrant health centers, and those 15 are generally known as voucher programs. Most of the migrant health centers are private nonprofit corporations owned and operated by community-based organizations. Some are operated by governmental entities, such as state and local health departments. Collectively, these health centers operate more than 700 satellite service sites in the U.S. The Migrant Health Promotion, Inc. operated a 2012 to 2015 grant project which aimed to improve the health and wellness of migrant and seasonal workers through health education and the Promotora model. You provide Gina with information about a prenatal clinic at the Migrant Health Center nearby and tell her to make an appointment in the next 2 weeks. Rosalina tells her that she will provide information on accessing migrant health centers in other areas in case they move. You give her a prescription for folate, explaining the importance of starting the supplements as soon as possible. You then describe the early signs of pregnancy and explain that she should call the clinic if she has significant spotting or bleeding or develops severe nausea and vomiting. Rosalina provides Gina with her phone number at the clinic and her cell phone number and explains that she should call with any questions or concerns. You use the teach back method, asking Gina questions to assess her comprehension of the recommended plan. You say, "Tell me how you will get an appointment at the prenatal clinic. When should the appointment be? Tell me when you should start the folate supplements. Tell me what you will do if you have spotting or bleeding. How can Rosalina help you? How will you contact her?" Gina demonstrates understanding of all topics, except when to start the folate supplements. You reiterate that she should get the prescription filled and start taking the pills as soon as possible. When you check her understanding again, she says, "I will get the pills today and take one every morning." Your clinic continues the use of Promotoras, and you are able to continue to work collaboratively with Rosalina. Rosalina keeps you informed about Gina, as she has stayed in touch with her through Gina's pregnancy and her move to another state. About 6 months after your visit with Gina, Rosalina reports that Gina has delivered a healthy baby girl and has found a supportive community of Latinas in her new home.